Good afternoon. I'll be presenting a case of excellent prognosis after immediate management in central retinal artery occlusion. My co-authors are Dr. Ayush Sangole and Dr. Ranjana Pandey. We declare no conflicts of interest and no financial disclosures. I present the case of a 53-year-old male with sudden painless diminution of vision since 30 minutes. The patient had no other ophthalmic complaints or no similar complaints in the past. He had no history of any systemic illnesses like diabetes or hypertension. In the general physical examination, he had a markedly raised blood pressure of 180 by 110. Rest of the general physical examination was within normal limits, and his systemic examination was also within normal limits. The ophthalmic examination of the right eye showed a visual acuity of 6 by 6. The iris pupil was normal in size and reactive to light. The anterior segment was within normal limits. And the left eye showed a visual acuity of hand movements close to face and a relative afferent pupillary defect. The fundus of the right eye was within normal limits. The significant findings in the left eye were a cherry red spot at the macula, box scarring of flow in the blood vessels, and retinal whitening with a ground glass appearance. The OCT of the right eye was normal. The left eye showed hyperreflectivity of inner retinal layers due to edema and hyporeflectivity of the outer retinal layers. The patient was given ocular massage. First, we used topical anesthetic proparacaine 0.5%. Then we used a 4-mirror Sussman gonio lens. The massage was given at a total of 60 minutes at regular intervals for 20 seconds, followed by sudden release for 10 seconds. At 15 minutes, we took an OCT and we observed that the hyperreflectivity is decreasing. Because there was improvement, we continued with the massage. We also gave tablet Dimoxstat. At the end of 1 hour, the patient's visual acuity had improved to 2 meters. He had significant corneal edema. The OCT showed reduced hyperreflectivity of the inner retinal layers. The patient was also medically managed with injection labetalol 20 mg in 10 cc NS over 2 minutes by the physician. The BP at 15 minutes was still raised and hence the same was repeated. They also gave him tablet amlodipine 5 mg stat. He subsequently took discharge against medical advice. The investigations he underwent were the following. The complete blood count, ESR, CRP, and RBS were within normal limits. However, he showed a grossly deranged lipid profile. The patient presented again to us after 17 days. He had been started on amlo and enalapril for hypertension by his physician and atorvastatin 40 mg HS for hyperlipidemia. The ophthalmic examination, the visual acuity was 6 by 9. The fundus showed tortuous vessels, rest of it was normal. The OCT showed reduced hyperreflectivity of the inner retinal layers. This is subsequent photos of the OCT. This is at first presentation when the patient was HMCF, then after 1 hour when he was counting finger 2 meter, and then after 17 days when he presented with 6/9 visual acuity. This is the fundus photo. Unfortunately, because we don't have a fundus camera in our OPD and it was an emergency, we just took it on our mobile. That's the left-sided picture, and the right is the fundus photo at 17 days when he was 6/9. So central retinal artery occlusion, basically you have a thrombus or an embolus that reduces perfusion to the retina. They have very poor prognosis and the presenting vision is in counting fingers to nil, no PL. It's an ophthalmic and systemic emergency which needs prompt management and urgent referral to a stroke center. You get a golden period of around 90 to 120 minutes to perform interventions such as ocular massage, paracentesis, giving acetazolamide, mannitol, or inhalation of carbogen. Despite all of this, it still has a poor prognosis. The theory behind ocular massage is that a steep increase in pressure and a sudden return to normal pressure will plunge the embolus distal into the vascular pathway with less catastrophic compromise to the retinal blood supply. So a prompt diagnosis and early treatment is crucial to dislodge or lyse the embolus and prevent irreversible retinal damage and blindness. These are my references.